about the PET CT and PET MR images. This is SAMEH KHALIL. First of all, our scope in PET cardiac, the first killer, sure, the coronary artery disease, and how to discriminate between myocardial infarction and hibernating myocardium ischemia, stunned myocardium, the cardiac tumor, the diagnosis of the pattern, is it malignant or benign tumor, and the pattern of spread also, and to detect the site, the proper site for biopsy correlation. Inflammation, the diagnosis of inflammation and the follow-up of the successful treatment management, amyloidosis and vasculitis. First of all, the first killer, as I said, the coronary artery disease. We use the rubidium and ammonia for perfusion study, and we use FDG for the viability study. We prepare the patient as in case of thallium or MEBI or stress MRI, and we give the same drugs, adenosine or dobutamine, and this is the normal perfusion of the heart. Normally, the tracer is distributed all over the myocardial segment in a homogeneous way. This is our axis, the same axis as cardiologist nomenclature, the short axis, 2-chamber, 4-chamber, and we do a stress study and resting study. We need to differentiate between myocardial ischemia, where we have defect in stress images, and reperfusion in resting image. This patient deserves revascularization either by stent or CABG. Similar is hibernating myocardium, but in case with hibernating myocardium, sometimes we found fixed perfusion defect in a perfusion rubidium or ammonia studies. So we need to refer the patient for another modality, the viability study by FDG or MRI viability study. And finally, the myocardial infarction, no hope for revascularization in this patient. All myocardium is infarcted, all myocardium is dead. This is the pattern of ischemia. We have inferior wall stress perfusion defect, which is corrected in the resting studies. Another patient, we have LAD, anterior, anteroseptal, and apical wall perfusion defect during rest, which is corrected during the resting study. And also, it is not a visual impression how to assess the myocardium. It's also a quantitative method. We need to measure how much blood going to the myocardial mass in a numerical way. Normally, we have 1 milliliter blood per each milligram myocardium, and this number should be 4 or 5 milli in stress images. So it is not just visual operator-dependent expressions. This is a case of infarction. In stress images, we have reduced perfusion, which is not corrected during the resting images. Inferior wall infarction. And the combination between the ischemia and the infarction. In this case, we have LED tertiary infarction as perfusion defect in stress, and it is fixed during rest, and we have reversible defect in the LCX distribution. This patient need revascularization for the LCX territory. And this is also a case with ischemia in the LAD distribution, which is corrected after that. Myocardial viability, either done by FDG in the world of PET or cardiac MRI. As regard rubidium, perfusion study, we have a significant number of patients of false positive result. So we need to go for further step in the viability images. We have three patterns in viability images: the mismatched pattern, where we have stress and rest perfusion defect in the rubidium images, while we have normal FDG distribution. So this hibernating myocardium is viable. This patient deserves the revascularization process. Or matched defect, we have rubidium stress and rest perfusion defect, and we have corresponding defect in the FDG study. Or the geoparadized myocardium, which means we have myocardium at risk, we have myocardium with stress perfusion defect and reversibility during the rest with rubidium, but no FDG activity. Again, this is the matched effect in the RCA distribution, and mismatched effect in the LCX distribution. Or combined three-vessel disease, we have perfusion defect in the LED, in the interventricular septum, which is corrected in the FDG study, while we have fixed defect in the RCA distribution. Limitation of PET. Sure, the case of right coronary artery infarction. This one of our patients presented with ventricular tachycardia. On MRI examination, we have subendocardial infarction in the left ventricle, and we have transmural right ventricular infarction. This is not the scope of PET-CT. And the very small subendocardial ischemia, as in this case, 36 patients present with myocardial ischemia and borderline lesion in the LCX territory. We have a stress perfusion defect, but this is very small to be detected by the PET-CT images. The other side is the inflammatory and neoplastic cardiological diseases. As regards the famous disease of sarcoidosis, we have the checklist of Japanese Ministry of Health and Welfare criteria. Mentioned that we have two criteria from the nuclear imaging world. I think in the future revision of these criteria, we will modify the nuclear tracers of gallium 67 and thallium by PET FDG studies. This is the traditional images of gallium, active sarcoid, above and below the diaphragm. And this is the images of FDG PET. We have edema in the T2 fat suppression short axis and two chamber views. And we have corresponding FDG activity. So we have an active cardiac sarcoidosis. Another case, we have delayed gadolinium images for chamber view. We have the patchy, corresponding to the granuloma, sure, the patchy delayed enhancement with gadolinium, and we have corresponding FDG uptake. So we have active sarcoidosis, active myocarditis. This is the images combined between the late gadolinium enhancement by MRI and the other limb of PET-CT. So please don't use one limb only. You have two limbs. You have very diagnostic and high spatial resolution in MRI, and you have a beauty of the functional images of FDG PET. And this is a case of perfusion defect in sarcoid scar. We have delayed gadolinium images. We have delayed enhancement in the LED territory. It is not acute insult. As T2 fat sat, we have no edema, and we have no FDG perfusion. So this is a post-myocarditis scar and dead myocardium. This one of our patients, this female lady was presented for us with sarcoidosis, cutaneous sarcoidosis. We did the PET-CT images for check the distribution of the disease. We have axillary, cutaneous, mediastinal, bilateral, symmetrical, which is diagnostic for sarcoidosis. So this is the value of combination of PET and CT images. The reversal of uptake in between the spleen and liver, and the periportal lymph node involvement. Also, we can monitor the treatment effect, as this patient with active sarcoidosis in the mediastinum and cervical region, we have complete resolution in the post-treatment study. The era of myocardial or cardiac prosthesis, and we need the PET-CT, the FDG PET-CT for the prosthetic valves, as in these patients from our hospital with left atrial appendage mass and mitral valve calcified mass. With FDG material, we have no activity in the calcified mitral valve mass, so it is caseous necrosis. And we have no activity in the left atrial appendage, so it is bland thrombus. The opposite is this case with prosthetic aortic valve and periprosthetic activity in the FDG images and the track of the surgery also, so we have active infective endocarditis. This patient with aortic valve replacement, we have peri-aortic abscess, and it is active also. This is the top view images of the aortic valve. And the beauty of PET images, it screens all the body. So we can diagnose this splenic abscess. We can search for the other infective endocarditis insults all over the body, not limited as cardiac MRI or transesophageal echo. This one of our patients, 5-year-old female, post-PDA closure. And now with CT, we have direct connection between the main pulmonary artery and the aorta, and we have filling defect, floating material inside this connection. And this floating material takes its route downward in the lung. This is completely behind the scope of echo. With FDG injection, we have activity in this filling defect, so we have vegetation inside the operation bed. And also, we have septic pulmonary embolism and septic infarction. This is totally beyond the scope of cardiac MRI and cardiac echo. Also, we have infection and aneurysm in the pulmonary arteries. This patient was operated, and this was aspergillus infection. Actually, patient was culture negative. One of our patients, status post-Ross procedure. In this patient, we have two aortic aneurysms and iatrogenic VSD. After injection of FDG material, we have perianeurysmal and perivalvular infection, active infective endocarditis. The other topic is cardiac amyloidosis. We have a specific tracer for amyloid disease, the fluorobetabin. This is the normal, and this is the diseased patient. As regard vasculitis, it is indicated in the equivocal cases, like not high elevation of the enzymes or the inflammatory markers or missed biopsy. in vasculitis, we can see the homogeneous, intense tracer uptake all over the blood vessel, and we can monitor the response of treatment on this uptake. This case, we have combination between the MRI images and CT images here. This is the CT images. We have aortic thickening and delayed enhancement in the aorta, while we have active inflammation with the PET images. Please take care of the atherosclerosis. The pattern of atherosclerosis is discrete and low active pattern. Also, we can pick the activity of infection in vascular grafts. We can differentiate between peri-aortic abscess, peri-aortic inflammation, and just simple aneurysm with this linear homogeneous uptake. As regard cardiac tumor, this was one of our patients referred to us, 33-year-old with possible right ventricular enlargement. You know, the right ventricle is totally behind the sternum, so it is a dark area for the echographist, so it was referred to the cardiac MRI. We have this infiltrative mass. So this is the combination between the diagnostic images, the spatial resolution of MRI, and PET functional images. We have infiltrative mass in the right ventricle, so we are sure this is malignant or aggressive inflammation. We have also a perfusion images for the tumor and delayed enhancement, but we don't know the extension or the spread of the tumor. Is it wise idea to take a biopsy from the right ventricle? PET response. In the PET images, we have activity in the cardiac mass, and also we have internal mammary lymph node and vertebral metastasis to be biopsied for this patient and to save his life from invasive maneuver like cardiac biopsy. We can monitor the malignant transformation also. This lady was referred to us with malignant fibrous tumor, and with PET images and the combination between PET and CT, we can diagnose the pericardial and impending right atrial infiltration. 70-year-old heart patient, non-compliant patient. We can't stand for 1 hour examination by cardiac MRI, but easily we can do PET images and diagnose the tricuspid and right atrial malignant infiltration, also the pericardial apical infiltration. And this patient was diagnosed with angiosarcoma. After we did the PET CT images, we screened for angiosarcoma or cardiac metastasis. This was the only active mass inside the body in this patient, so this was cardiac angiosarcoma. Also, this patient, from our patient, presented with leukemia or lymphoma, and we have this uptake all over the pericardium. We have a case of extramedullary infiltration of the leukemic cells. This is another patient with the same diagnosis. And this patient was referred to us as just a pulmonary embolism. We have these images in PET, this mesothelioma, which was biopsy proved later on, and it is infiltrative to the main pulmonary artery, the left major branch, sending lung mets. So this patient was beyond surgical correction. Thank you.
Thank you very much. We have a couple of minutes, 10 minutes for discussions. Are there any questions from the audience to the speakers?
Okay, thank you for all speakers. It's actually one of the best sessions I attended this conference because all 4 topics were interesting and informative. I start with a question to you, Dr. Zamsik. I worked a long time ago with the iron oxides in Harvard with David Stark. We were doing liver imaging and using iron oxide to detect metastasis, exactly as you said, uptaken by the normal von Kupffer cells, and the metastasis will appear bright on a dark background of the liver. So, and then there were a lot of literature about using them for lymph nodes in different aspects. Now, my question to you, first of all, you mentioned that you need to bring the patient like 24 hours later. Is this correct? Or is it in the same day, like 6 hours or something? So this
yes, there are 2 different things, also 2 different substances. What you are talking, so the lymph node diagnostics have a bit different principle than the liver diagnostics. If you want to have a lymph node phase, the lymphotropic phase of the USPOs, ultra small particles, iron oxide, you have to wait it 24 to 36 hours. Why? Because the particles, the ability, biological ability of nanoparticles is so that they are, to be honest, even not that attractive for macrophages to be eaten. Why? Because it's prolonging the circulation time in your body, so you do not have the effect of the first pass filtering out by spleen and by liver, like by other SPOs, like former Reservist now is already again registered in Germany and in Sweden. I can tell you something about it later. So you are prolonging the circulation time because the very small iron particles are not filtered up from the liver and from the spleen. That's why you are offering these nanoparticles in the peripheral bloodstream to the macrophages. They are taking it up and actively transported into the healthy part of the lymph nodes. In the liver diagnostics, the abilities of the particles are a bit different. So they are specially designed just to be filtered out mostly by the first, second pass through the liver and through the spleen, because you need to have a very high uptake of iron in the liver. So the normal liver, say it very, very roughly, the normal liver is then black because of the high iron content, and everything what is left is then not normal liver tissue. You can further differentiate. In this term, it's very important to just to say one, how to say, pharmacological feature of the ferrum carbotran, which is the former Reservis, now Resotram, that is a perfect angiographic blood pool agent, so you do not have any diffusion in the interstitial space, so you can make and combine protocol within one session that you are giving. That's the only one iron-containing contrast you can give as a bolus. So you can make your, for example, your early arterial phase, your venous phase, and then your specific hepatic hepatobiliary phase. So that you have an angiography or the macro angiography, if you want, of the lesion plus the specific liver phase in one exam.
Okay, just one more question so that not to take all the time. If you have a PET-MR using PSMA and the nano, would you go for PET-MR PSMA because now you are combining the high resolution of MRI and the small voxel sizes with the PSMA and doing the exam for the patient in one day because of the compliance? So what's your idea about this?
In principle, I always guiding myself looking on the clinical situation of the patient, because they could be of course different. So normally, for example, where you definitely need everything what you have is a recurrence, especially after radiotherapy or even primary prostatectomy, lymphadenectomy, then local recurrence, radiotherapy, and then again recurrence. We are getting pretty lot of this kind of with the patients. Then you have to use all what you have. MRI of the local prostate bed, because you have some recurrences, especially after radiation therapy, they could be PSMA negative. You need definitely PSMA because the deposits could be somewhere in the bones, and in our experience is PSMA at the moment the best tool how to detect even small bone metastasis. You can detect also greater masses somewhere in the body, and the nano MRI is a very highly specialized tool to detect small lymphatic or lymph node metastasis deposits in a pelvis. So it depends on the clinical situation. The use of PET-MR, it is my personal opinion, it's actually not that necessary, because PET-MR, as any machine, you are combining something with something. You have some technical compromises you have to do. And from my perspective, as an imager, as a diagnostic person, it's not that important for me if I have one image from one machine or two machines, and I can combine it with a fusion software and whatsoever. So, of course, you can imagine that you have situations that you have different of discrepancies, no, between two exams like PSMA and later on nano or vice versa. But normally, in more than 99% of the cases, if you have a positive lesion on PSMA, you can normally find it back in a nano and vice versa. That's normally not the problem. So if you have PET-MR, it's nice. But if you don't have it, it doesn't mean that you have worse diagnostics. It's definitely not true. If you have beautiful 3 Tesla machines with nice gradients, you have a new generation of PET-CTs with a good detectors, you are state of the art. So it's nice to have, but it's not a condition to have a high-end diagnostics. That's approximately how I'm looking at that.
Thank you.
Are there any other questions from the audience? Maybe I have one on the last speaker, Dr. Salman. The question, there was very impressive images, to be honest. Some of them I saw for the first time in my life. Just one question, just for my orientation. Do you see a lot of exacerbated sarcoidosis cases in Egypt? Is it something which is a local problem? Because this is something very, very rare. We normally do not see in the Netherlands.
This case with widespread sarcoidosis, this was one of our cases in Ain Shams University, actually.
So that is, fantastic. Are you think about it to make a publication about it, like case reports?
We did a publication. The young patient, 5-year-old, we published it in the Eurorad as a case report.
Okay, but this is really unique material, so I think a lot of other people are even not thinking about it, maybe to use it.
You are welcome, and people are welcome also. Thank you.
Okay. So it is time now, so thank you very much attending this session, and have a nice day. See you later.